Yeah, congrats.
Thank you.
Congratulations, ma'am.
I think for me, Dr. Surendran will always remain my head of the department. He has been my biggest support in all these years, and he's always provided unconditional support for everything which I have done or wish to do.
Ma'am, we are live.
Okay, thank you so much.
A very good evening to everyone. It is my great pleasure to have everyone join in on this fantastic webinar, which is something called Second Chance. Second Chance, it's strategies for strabismus re-surgery. So why such a complex case scenario, or why such a complex name? So when I was putting my brains into action and trying to think what is it different that we have been discussing, what is it different that we have not been discussing, and I asked my colleagues, Dr. Janil Sheth and Dr. Manjushri Bhate, to give their inputs in what could be discussed in a webinar about squint surgery or strabismus surgery. So I'm sure that most surgeons are very clear about how to approach this particular entity. But I'm not sure if every squint surgeon is very confident about handling when you have to do repeat surgery, when there's a residual squint or some other reason, something goes, like there's an oops movement and something goes wrong. So with that, it's a pleasure from the scientific committee with my colleague, my chairman, scientific committee, Dr. Namrata Sharma, and my colleague, Dr. Amit Porwal, to welcome everyone. I'd invite our chairperson, Professor Sharma, to welcome everyone before we hand over to the moderators.
Thank you so much, Somshila. And I would like to congratulate the organizers of this a wonderful webinar. The title is very intriguing. The Second Chance Surgeries for Strabismus Re-Surgeries. And I'm sure it's going to be a great learning experience, although it is a slightly focused title only to the subspecialty. But I think all ophthalmologists would definitely benefit from this. It's a very nicely crafted program which almost covers everything. And I would particularly like to congratulate Dr. Manju Bhate and Dr. Sheth for doing this. And thank you so much, Somshila, for coordinating the whole webinar and doing it so meticulously. Thank you, and over to the speakers and the panelists of the session.
Thank you so much, Dr. Namrata, Dr. Somshila, and Dr. Amit Porwal for giving us the opportunities. So, Janil Sheth is a faculty at Shantilal Sanghvi Eye Institute in Mumbai, and I'm Dr. Manju Bhate, faculty at LV Prasad Eye Hospital Institute, Hyderabad. We'll be moderating the session, and we have a panorama of eminent panelists and speakers for the session. So we'll straight go into the session. Maybe Janil, would you like to just quickly introduce the panelists?
Yeah, so we have divided panelists as per the section. First of all, a very warm welcome to everyone. Thank you for giving your Saturday evening for this session. And this is a very interesting topic, I'm sure, to everyone, and challenging as well. So we are going to have Dr. TSS from Shankar Netralaya and Dr. Pradeep Sharma, both stalwarts of probably together 100 years of experience in strabismus. I'm sure the resurgeries is where you would have seen everyone's resurgery and you have picked up that what are the nuances of it. So for the section one, Dr. Shailaja is going to start her presentation, and we would like you to give comments and discuss with you. And as we move forward, we'll have the other panelists also to be included. Dr. Shailaja, if you can please share your presentation.
Yeah, thank you. Is my presentation visible?
Yes, if you can put it in the slideshow mode.
Yeah. So without much delay, I'll start the presentation, and just before that, I'll just thank the AIOS office bearers, especially Dr. Namrata Sharma and Dr. Somushila Murthy and Dr. Porwal for this opportunity, and Janil and Dr. Manju for this wonderfully crafted program. And my very good evening to all the esteemed panelists. and chairpersons of this session. So I have been actually given the, the responsibility of starting it and just giving an overview. So I might be rushing into things to cover it in 7 minutes. So, but most of it is kind of getting covered in detail in the rest of the program. So, a planning of resurgery and optimal outcomes after strabismus surgery is, I think, after 1 or 2 years of your practice into strabismus surgery, when you practice into strabismus, that when you start thinking of planning, because then is when you start getting some of these cases, and when you think, oh, what to do next. So there are some of the very interesting articles, and one of them is one which I'll be quoting mostly in this presentation. First and foremost, how to define a suboptimal outcome. So it could be a residual or a consecutive deviation. And mostly it would be defined in most of the studies if it is more than 10 prism diameters of a tropia after strabismus surgery. And it is usually taken after 4 to 6 weeks after surgery and not just immediately post-operative. It could also be recurrent strabismus, where it is usually considered when there is a period of stable alignment or good alignment, following which the strabismus recurs. In many papers, the residual and the recurrent strabismus are taken, together. And there could be new deviations after any strabismus surgery, or a new kind of vertical deviation in a horizontal strabismus surgery, or a horizontal deviation in strabismus surgery. Those kind of things can also happen. So the incidence is quite variable in different papers, but it is going even up to high as 60 to 70% in some of them. Especially recurrent exotropia or intermittent exotropia to recur is much more common as compared to the other kinds of deviations. These are the various percentages. I'll not go into the detail, but first and foremost, whenever it happens, we have to think what went wrong. So, as a beginner, first thing that comes to our mind is, what did my measurement go wrong? And so measurement errors comes first, and you have to go back and see whether you took, ample number of times measuring whether the patient was cooperative or not, what went wrong, and things like that. But over time, you realize that, that's not the main factor in after a couple of years of practice. So, but you could have missed pattern strabismus, oblique dysfunction, or DVD at any point of time. So these are the important things that you need to, watch out for in all of your preoperative measurements. There could be a dosage error. But then more commonly, you have to look out the risk factors if there are any. In fact, this would be involved in the planning of the surgery per se, but these are the risk factors which, kind of predisposed to recurrent strabismus or a residual strabismus, and even consecutive deviations. So amblyopia and poor vision is one of the most common, which causes, kind of a residual deviation. The type of deviation, like some of the deviation characteristics, like having a divergence excess exotropia, or a high AC by ratio intermittent exotropia, or a lateral incompetence in exotropia, kind of predisposes to having a consecutive esotropia after surgery, especially for neo. Incomitant and restrictive strabismus are more prone to, have residual deviations or overcorrections. Presence of DVD, in fact, if whenever you correct, there is a 50% chance that it would be undercorrected. And nystagmus surgery also leads to suboptimal outcomes many times. Age is one of the factor. Children, there is more chances of having a suboptimal outcome as compared to adults who are considered to be more cooperative. Neurological factors like children with CVI, children with seizure disorders, they are more prone to develop suboptimal outcomes. The preoperative deviations, large deviations, have more undercorrections, or even, unpredictable kind of outcomes. Even refractive errors have some play into it. Long-term loss of fusion is another factor which can lead to a suboptimal outcome. All in all, we are tackling a complex neuromuscular and sensory system via just the motor system. So these things are bound to happen, and it will happen to everyone. So if there is an unwanted result, what to do? First of all, stay calm. The important thing is to have a correct dialogue with the patient even before the surgery, telling them and warning them about suboptimal outcomes. And once it has happened, you should not neglect your patient, rather than own the patient even more. Be with them, try to explain the results with them, and try to explain the options for the management of the patient. You can even try the conservative management. I will not go into detail because this is a surgical webinar, but conservative treatment, especially in some kind of strabismus consecutive deviation like consecutive esotropia, maybe as effective in 80% of the patients if you wait for 1 year. And vision therapy, prisms, and alternate patching are some of the modalities of conservative treatment management. So if you think there is an operable residual deviation, then what is it and when should you intervene? So immediate intervention is called when it is within a week, and that is required in specific types of suboptimal outcomes, especially consecutive deviations which are associated with unexpected limitation of ductions or a new large vertical deviation. So this usually signifies that there is a muscle injury which has happened, like a lost muscle or a slip muscle or a adjacent muscle injury. So there you have to intervene as early as possible. All the others you can wait, and late is considered when it's anytime after 4 to 6 weeks of surgery, but usually it is advisable to wait for around 6 months post surgery. For a deviation more than 15 to 20 prism diopters, you would want to go ahead and do a surgery. Below that, better to do go ahead with a conservative management. And the other types of other indications for surgery, like possible sensory fusion, any disabling diplopia and cosmetic blemish is also indication for surgery. So this is an example of a lost or slip muscle where there would be large deviation and correspondingly a large limitation of duction. At the same time, there would also be there could be a palpable fissure widening when the eye is moved in the direction of the slipped or the lost muscle. When you approach the reoperations, it is important whether you know the complete information of the prior surgery, which would usually be when you have only operated or somebody within your team has operated, or incomplete information about the prior surgery, which is mostly or the usual case. So in those cases, old photographs may be helpful. Like in this patient, it was esotropia to begin with, after surgery straightened, and then later on exodrift was seen. You can contact the surgeon if you know them and ask them for the details. You could look for conjunctival scars. Ancillary tests would be covered later. And last option is go ahead and explore, preferably do it under general anesthesia. The choice of surgical procedure, this is the article which I was talking about. It's an old article, but still very relevant. And Kushner mentions that you have to see the ductions and aversions, measure deviations in all gazes. There could be subtle signs of underactions which you need to pick up. Intraoperative FDT and spring balance tests are also helpful. This is the kind of flow chart that he gives, whether to touch the nave muscles or the previously operated muscles. I think again it would be covered subsequently, but I'll show a few cases. Now this case this is the same case of the photograph where both medial rectus where surgery was done in childhood, and there was a gradual diphthering after 4 years of the surgery. If you look here, there is a subtle or a mild adduction limitation in the left eye, slightly more than the right eye, and the near deviation is more than the distance deviation. Otherwise, the distance deviation is quite comitant in all the gazes. So this kind of tells you that there is some kind of medial rectus underaction. So go ahead.
Dr. Shailaja, we
I
cannot
think
hear
we
you.
lost your voice, Dr. Shailaja. Have you muted yourself? Yeah, go on.
How much? Most
Yeah.
of it?
No, just
No,
last.
now we can hear you. Also, can you wrap up because we're
I just finished.
yeah.
So this is a case again showing just two more slides. So this is a case again showing a near distance disparity in a consecutive esotropia, again hinting towards underaction of the lateral rectus muscles. So go ahead with bilateral advancement. A case of residual esotropia, which is large esotropia. So here 3 muscles were already done. So a transplantation with of the resected muscle, fourth resected muscle to the already recessed muscle was done. And lastly, one should be always be, whatever you plan, you should always be ready for surprises. In cases of re-surgeries, you could meet with stretch scars, a pseudotendon, or even thin muscles, shifted muscles, extensive scarring, or conjunctival shortening. Thank you.
Thank you so much, Dr. Shailaja, for giving a great overview of all the possible options that we can look at re-surgeries. And I really liked your stay calm and have a good dialogue with the patient, because having patient confidence is so important. We'll move on to the case and the video and then have a panel discussion at the end. So for the case, I invite Dr. Sujata Guha, who is at Shankar Netralaya, Calcutta. If you could please share your screen and
Is it visible?
Yes, thank you.
So a very good evening to all of you. And at the outset, I would like to thank AIOS team and Dr. Manju for the invite. I'm going to present a case of consecutive esotropia in this 24-year-old young man. He presented with outward deviation for the last several years. Good vision, both eyes, no gross refractive error, measured about 75 prisms of exotropia for distance and around 90 for near with a small left hyper. The ductions were full and there was no diplopia on offset. So we planned a recession of lateral rectus around 7.5 and a medial rectus resection around 7 millimeters. And post-operatively, we had a large consecutive esotropia of 20 prisms for distance and 14 for near, with the abduction limitation more for the right than for the left, and diplopia. The patient complained of diplopia. So, we thought, what could be the cause of such a large consecutive? Could it be overcorrection, wrong dosage, like it was mentioned? But we had planned according to our usual standard tables. We also kept the possibility of a lateral rectus slippage because there was abduction limitation more on the right. We did an MRI. The lateral rectus was there in the same place. So we planned a second intervention, thinking it could be a slipped lateral rectus. At around 11 weeks, a lateral rectus exploration was done, and the lateral rectus was found to be at the same place where we had kept it, around 7.5 millimeters. It was advanced. There was a lot of fibrosis. So once we found it, we advanced it to its insertion on an adjustable suture. And post-op day 1, we left the patient with a flick exophoria for distance and near. On the second 6 weeks post-op for the second surgery, we had a consecutive of 10 prisms of ESO and 4 prisms for near. There was the abduction had improved, but the diplopia still persisted. We gave the prism, we gave the patient 5 base out prism in both the eyes, but the diplopia still remained. So what could we have done a little differently in the first surgery? We thought we had over-resected the medial rectus, and medial rectus being a very strong muscle, resecting the medial rectus with a nearly equal recession of the lateral rectus could have given us the additional effect. And this large medial rectus resection could actually be a restrictive element causing abduction limitation. So we thought we could have increased in the first surgery, we could have increased the lateral rectus recession a little more and reduced the resection a little less. So what are the learning points from this? We learned that 4 muscle surgery is not equivalent to a double of 2 muscles. It gives exaggerated results for the same amount of dosage when it is done bilaterally, and therefore you should reduce the surgical dose and preferably put these patients on adjustable suture. Medial rectus resection, a large resection can cause restriction, and a 3 muscle surgery is a good alternative for large angle strabismus. We can stage the surgeries. The first surgery can give us the maximum, we can do the maximum surgery in the first stage, and then titrate the second surgery depending on how we got the results. Thank you.
Thank you so much. So that was really interesting, and all your learning points of staging surgeries or taking things step by step, and when we can, land up overcorrecting was really useful. I think we need to bring our 100 years of experience now to give us some comments. So I'd really like to invite Dr. Surendra and Dr. Pradeep Sharma to please give us your expert opinion on the first two presentations, and then we'll move on to the video.
I think it was a wonderful presentation by Shailaja, covering up most of the things to start with. I think we will be discussing more of that one by one. I would like to specifically mention about the case because that is something which we need to. The choice of doing an MR resection of 7 is really amazing to me. I would never do that. That is something which we usually say the equity between MR and LR has to be in the ratio of 1.5 to 2:3 or 1.5 to that. So from 7.5, 5 would have been the MR to balance.
Yes.
So I would feel that would have been, I mean, it's like a red flag to me. At the first instance, I was thinking there would be a problem. So I think that is something which we should always remember. MR being a muscle which has a very short length towards the equator should not be over recessed or over resected. It has very few, I mean, the safe limits are little. Lateral rectus that way has a more leeway, and you should be doing that. So that is one take-home point which you have already taken, that MR should not be resected. Secondly, I don't see the fact that you did an FDT at the second stage. In fact, at the end of the first surgery, I would always expect a person to do an FDT, that after the resection or the advancement of the MR, you have ensured that the FDT is not tight. I generally tell that, yeah, FDT should be done. And if you find that the resection is not allowing the lateral rectus to abduct on the table, you will have to reduce the amount.
We did.
So these are the two, I think, points which I would like to suggest at this moment.
Thank you so much. Dr. Surendran, please would you also give your opinion?
Unmute. Dr.
I think
Surendran,
you're muted,
unmute yourself.
The second case actually preferable to do 3 muscles, the first stroke, and then anyway, I think she has gone for the second stage, the Sujata case.
No, it was done in our institute.
Okay, 3 muscles, first stage, and see the results, because it was not crossing more than 120 prisms. Then I think we can attempt to take the risk of doing all the 4 muscles. It was less than 120 prisms. Maybe I think 3 muscles first stage, and then go for the second one.
Yes.
We might have avoided the overcorrection.
Yes.
And I think first stage, I think first case, I think Pradeep has covered very well. So I don't think there's anything. And did you see for divergence, true divergence excess in this case?
We did. There was a distance near disparity, yes. But it was such a large strabismus that...
More of a convergence insufficiency, I think. No?
Yes.
Anyway,
great.
That I think adjustable suture would have been a choice for the second stage.
Yes.
Sometimes you can think of Botox also. No? Botox.
A medial rectus recession would have been a better second choice.
Yeah, the overcorrection was not that much, but only
instead of pulling up the
lateral rectus. Yeah.
Diplopia was the problem. So maybe a short dose of Botox, or what we can do that. How long you waited? That can
11 weeks.
We thought we had the lateral rectus had slipped.
If I may quickly ask, in such cases, would you look at the PFH size also to get some clues about whether it was tightening of the AMR or
FDT, size of the PF, all of that.
So during the abduction movement, if it's slippage, then the FDT is much
lower. Saccades are a little slow. Yeah.
Right. Great. So let's move on.
Second stage, there's also, I think, this angle, what Sujata had, I think a Z myotomy. Z myotomy of the medial rectus. Just extending the muscle, lengthening the muscle works very well for that small deviation. and trying frenal prisms for some time. And I think if there is a binocular vision stereopsis was there, I think that corrects. Anyway, we'll go to the next. Thank you.
Thank you so much. I'd now invite Dr. Sumita Agarkar, who is the Director of Pediatric Ophthalmology at Shankar Nethralaya, Chennai. So over to you, Sumita, for the video. Thanks.
So thank you, AIOS, and all the scientific committee members for giving this opportunity. This is the summer season, and all of us are facing our old cases back of various stages of satisfaction or dissatisfaction both. So I'm going to show a small video on advancing the recessed muscle. So this is a typical case you will get in our country. Squint correction, no old photos available, no records available. But in this case, at least she had good medial rectus scar on both eyes, and there was an abduction limitation, as you can see here in the left eye. And we decided that she needs very large exotropia, so we decided bilateral lateral rectus resection, and we decided on advancing the medial rectus in the left eye. So in any recession, the first step is to do FDT. Then here, since this is not this person's video, this is my own, another patient's video of advancing. But if you know the detail, if you have done the surgery, you can probably use a limbal, not a limbal incision. But if you have not done the surgery, then probably it's better to safer to use a limbal incision rather than a fornix incision. But since here I was the primary surgeon earlier, I was able to hook the medial rectus fairly quickly. And you have to take a really good bites in that. And then, but the actual patient whom I saw, their surgery had been done elsewhere with no records. So here I actually went for this is the patient whose pictures I showed. So you can see there was a limbal incision, and I have made a limbal incision, and you have to probably pass on. But luckily, no scarring in this patient. And with one pass itself, we found the medial rectus. I was able to take the suture. There was not much of scarring. And the Iranian surgeon who had done the earlier surgery had done a really good job. Now here, it's important that your limbus is the undisturbed thing. So you should probably use limbus as your landmark rather than the actual surgery. And then you should advance it to whatever advancement your muscle allows, because remember, these are the surgeries where the muscle has already been shortened. So don't try to advance to the original insertion or pull as much, because then you will end up with a little bit of a pulled into syndrome. So advance what you can. And as Dr. Sharma also mentioned, FDT before and also after to see how much. So here also, again, I was able to advance nearly. And since this was already operated elsewhere, I actually took a 4-point fixation, and I fixated it at 2 points at the center, as well as I have taken a peripheral white again and gone in ahead to make sure that it doesn't slip. And I was able to advance almost 4.4 millimeter in this patient, nearly back to her original insertion. So this is how you will advance. And this is her postoperative result. As you can see, fairly good postoperative results we have got with 3 muscle surgery. This is another case where I have done, and I had done surgery, bilateral medial rectus resection as well as lateral rectus resection. And she has come back with a fairly large residual ET. And I thought that my resected lateral rectus has slipped. So actually I went and because there was a little abduction limitation, and as Janil was mentioning, a little palpable fissure widening, especially in this eye to this eye, if you see. So again, this patient also, I did plan to advance a lateral and do a further resection of the medial. Again, we start with FTT. You can, since I was the primary surgeon, again, I have chosen a fornix incision, but you can experience scarring. And here, important thing to remember is, because of the scarring, see if here I have inadvertently actually hooked inferior oblique also along with my lateral rectus. So this is something which can happen, and you should be vigilant about it. Because of the scarring, everything looks pink, everything looks red. But like, as you can see, I finally rehooked, and I have left the inferior oblique alone from that. So this is something which you need to be vigilant, especially if you are advancing the muscles which have connected or closely linked to the obliques. So I did the surgery, her abduction has mildly improved on the day 1, but she still has a residual ESO. I actually did a little bit further recession of medial rectus also, but I think she might need another surgery. So carry home message when you are doing advancement, FDT, limbal incision if you are a beginner or if you don't know the details of surgery, anticipate scarring and bleeding at both points where you have actually left the muscle and where you disinserted, and do a sharp dissection using a scissors and not blunt dissection. Do not go around fiddling with your hooks there. Beware of inadvertent hooking of oblique, which can happen. Use limbus as an anatomical landmark because limbus has not changed. Your muscle positions may have changed, so use limbus. So differentiate between a stretch scar and actual muscle. I think there is another about lost muscle. So when you have hooked the muscle, and even if you think that you have hooked the muscle, it's always good to go back and do another pass behind whatever you have hooked to make sure that there is not stretch scar and actual muscle may be actually attached behind. So when you're advancing, your suture should be in the muscle and not only in the capsular fascia. And muscle may be shortened, so advance to the limit you can. Secure the muscle adequately if you feel not sure. And if you're planning another surgery, then advancement can give a little unexpected results. So it's always preferable or ideal probably to leave other muscle on adjustable to optimize your results. Thank you for your attention.
Thank you so much, Sumita. And all these were great learning points, I think, from all that you've said. Doing a limbal incision in a redo surgery can be very valuable, can provide a lot of ease in the dissection. Also, what I used to learn from my mentors, Dr. Martin used to always recess or often recess the conjunctiva as well sometimes, because that also can have a bit of shortening. So great take-home points. I think we'll move on to the next section. We can always come back to more discussion. So I'll just ask Janil to start with moderating the next section. Janil, please take over. Thank you.
Thank you, Dr. Manju. It was an excellent first session. So before we begin with the speakers of the next session, I would like to introduce our other panel members to whom I would like to ask their comments in this second section, which is more of imaging and that what are the different imaging modalities. So Dr. Shubhangi Mave, a very senior pediatric ophthalmologist and probably more than 30 years of experience in strabismus from Nagpur. Welcome, Dr. Shubhangi. And Dr. Jyoti Matalia, who heads the pediatric ophthalmology department at Narayan Nethralaya, Bangalore. She comes with a very vast experience. Welcome, Dr. Jyoti, to this session. And we have Dr. Ramesh Kekunia, who leads the Pediatric and the Child Sight Institute at LV Prasad Eye Institute, Hyderabad. Dr. Ramesh, welcome to the session. So without further ado, I would like to also welcome our first speaker of the day, Dr. Savleen Kaur, who has published extensively in anterior segment imaging of rectus muscle in re-surgeries, and something which we did not think of many years ago. She comes with vast experience in such things. And Dr. Savleen currently is a faculty member at PGI Chandigarh Prestigious. Dr. Savleen, I would request you to kindly share your presentation.
Thank you so much, General. Thank you so much, Dr. Manju, for inviting me to be a part of this. I'm sorry, I have a bad throat. I hope I'm audible.
Yes, you're audible.
Yes, you're audible. Please go ahead.
So since we are talking about imaging, I would just, because we're having a webinar on redo strabismus, so we all know how common it's to encounter such scenario, and patients rarely don't know their histories, and we are often not the primary surgeon. As Shelja and Dr. Sujata's case, as well as Dr. Sumita has told us that we do need to do a thorough clinical examination along with previous history and photographs to be reviewed. But still in 30% of these cases, our muscle attachment might be defective. So I think that is where imaging comes into picture. So I have 3 cases that I wanted to show in order to highlight the 3 most common imaging modalities that we can use. Beginning with the ASOCT, I'm sure we're going to talk about it in the future talks as well. So this is a simple case of a left exotropia, visual acuity of both eyes. The patient is giving history of squint surgery in childhood, but she doesn't have records. So the ocular motility is normal, and do see some scarring on the medial conjunctiva of the right eye, indicating that the right eye was operated. So we follow Cooper's dictum, an excellent article that Shelja also shared. So what do you tell the patient? You want to tell them that you don't know what you will find intraoperatively. Probably you want to undo what was done and offer them an exploration of that eye, as well as in case of suboptimal outcomes, you tell them that you will do the other eye surgery. You might need to do it. So what we did was the AIOS, and this is how the muscles look like. I would like you to look at the picture on the right first. So this is the right eye lateral rectus, which is seen as a black hyperreflective band. Very clearly seen, the outer coats are normal, and this is pretty much how an unoperated muscle looks like on the AIOS. On the other hand, the medial rectus of the right eye, we couldn't image it till the distance we could image on the AIOS. We do see some hyperreflectivities, but these are just scarring, and the muscle. On the other hand, again, if you look at the lateral rectus, it appears unoperated. And the medial rectus, we could see that we have the medial rectus, but recessed farther back than where it should be. And the sclera in front of the medial rectus also showed some thinning. So both eye medial rectus have been operated. She's a case of consecutive exo, but we plan to do one eye, that is the left eye first. Why? Because we thought that there are higher chances that we might find the left eye medial rectus intraoperatively with lesser difficulty, and we'll have lesser scarring because it appears a little, closer to the limbus than it should be. So we recessed the lateral rectus of the unoperated left eye, giving the advantage of an unoperated muscle as well as advanced that operated medial rectus. Intraoperatively also, it was a fairly well done surgery, and we kind of reproduced the results that we obtained on AIOS, and by operating only one eye, we could get a fairly good outcome. So it's very helpful to do AIOS if you have access to the machine when you do not know what the previous surgery was. It can help you decide the reoperating eye. And even once you have case records, sometimes it can tell you why there was a recurrent or a consecutive strabismus in the form of scarring, which has led to this suboptimal outcome. You can pick up pseudotendons on the AIOS, and also larger than usual recessions can also be picked up. We did publish our own results where we saw that AIOS could go as far as 14 mm, and we could actually pick up larger recessions with this technology. There has been a limited literature on AIOS in reoperations alone, but the efficacy has been to the extent of 60 to 80% when we are measuring the muscle up to 2 mm. The second case scenario that I want to highlight is where AIOS might not be very beneficial. So this again is the case of right exotropia, a patient having an open globe injury followed by retinal detachment. The retinal detachment was repaired with a 360-degree band, and 4 years later, the patient underwent a right eye strabismus surgery. The note said that the patient underwent a lateral rectus recession, but the patient's dialogue with the surgeon, what he conveyed to us was that the surgery was abandoned in between. They could not get a fairly good outcome. He was aware of it because of the band, probably, that they could not get a very good outcome. So now the patient is having an exotropia of 45 and the motility is almost okay. Now remember that AIOS is an optical method. So both the band, buccal, or any exoplant for that matter will also be hyporeflective. So if you can see the video running at the bottom, we are trying to scan throughout from top to bottom. We can make out that there is some muscle that can be seen, but then we do not know what is its relation to the exoplant that is there. So here we actually did a UBM. And as you can see on the ultrasound biomicroscopy, because it's a sound waves that is being used, the depth becomes a little more, the resolution goes down. So what we could see was that we could see the muscle, and we could also look at the band, and we could find a relationship between the two. And we measured the lateral rectus to be recessed a little, and medial rectus more or less at the normal position. These muscle insertions are altered in places in presence of exoplant usually also. So intraoperatively, we did find there was a lot of scarring adhesions, but the lateral rectus was recessed up to 9 mm as we detected on the UBM. We kind of, did a hangback recession in this case beyond the band. And we also operated on the medial rectus to give the patient, a satisfactory cosmetic outcome with a contact lens. So in cases where you have an uncooperative child, I think are my indications of doing a UBM. You can take the patient to the OR if you have access to the machine, because their UBM can be done if AIOS is not. In presence of other ocular comorbidities, in presence of glaucoma valves, in presence of these exoplants after retinal surgery, I think the UBM might be a little more advantageous. although the efficacy of the measurement is known to be equitable between the UBM and the ASOCT. The third case scenario that I want to highlight is MRI, where you can't do an ASOCT in UBM. So this is a case of a 35-year male who had a trauma because of a fall and injured his left inferior rectus, which was operated upon outside. I will thank Dr. Vivek Walkart for the help on this case, because the patient presented to me with a 16 prism diopter hypotropia. Now, the inferior rectus was already explored, and the note said that they had tried to repair it. And as you can see, the sockets were reduced, but the patient could still depress a little bit, and we could see some fullness in the inferior lid, and we were suspecting what is happening to the inferior rectus. If it's attached, why is it not gained its normal function? When we did the ASOCT of the right eye, you can beautifully see the inferior rectus. We have shifted to the BLEB module for this. But the left eye inferior rectus is all haywire. There's a lot of scarring. In this case, you will not be able to do, not able to see much on the ASOCT as well as on the UBM. And these are the cases which I think, to my mind, require neuroimaging, because posteriorly you want to know how the muscle is. So we could see the inferior rectus posteriorly intact. We did a dynamic MRI as well. When the patient is looking in the up gaze and down gaze, we did see some movement, but the attachment between the posterior and the anterior part of the inferior rectus seemed a little thin. So the radiologist also felt that there was something going on in between the muscle, and intraoperatively saw that it was actually lacerated. So for the first go, because it was immediately post the first surgery, we did not do much. We just sutured the inferior rectus through and through. And post-operatively, we actually saw that the patient was orthotropic. And I don't have much follow-up photograph for this patient, but he does seem to have a lot of, good depression, and he's not complaining of diplopia. So in cases there is a trauma to the muscle, maybe endoscopic surgery, or you have a large restrictive strabismus, are the indications where you want to do a neuroimaging and not ASOCT or the UBM. Where large slips, you want to do the MRI. And in cases of complex strabismus, there's an excellent paper by Dr. Deemer where he details the situations where you would want to do an MRI. Obliques cannot be imaged on the ASOCT and the UBM, and if you are planning a reoperation on an oblique, you can attempt at the MRI. It's very good to look at the imaging. The bulk of the inferior oblique can also be very well appreciated on the MRI. And in difficult case scenarios like craniosynostosis, I think are the indications where you would want to do an MRI. So every technology has the constraints of availability, time, and expertise, and along with the expertise that you have and the availability of the machine. But still, our gold standard remains a thorough clinical examination, and on table, what do you find? So to conclude, imaging can be beneficial in select cases of strabismus reoperations. You can counsel the patients better. I think you're more prepared if you have some results on the imaging, and it will make your results more predictable. These are just complementary ancillary tools, and the most sophisticated instrument, you might have access to it, but you should not use it without a thorough clinical examination. So thank you very much. I think all my second chances are looked upon by Dr. Jaspreet. So thank you, sir, for that. And thank you again, AIOS, for inviting me.
Thank you, Dr. Salvin. Excellent summary of all the imaging techniques. I think this brings more confidence to the surgeon as well as the patient before doing the exploratory and having surprises. Before we move to panel discussion, I would like to invite Dr. Sampada, who is again going to give a very interesting case of imaging and its role in a case of strabismus. Dr. Sampada is a faculty member of V. Prasada Institute, Hyderabad. Good friend of mine. Sampada, please go ahead, and we'll have the panel comments discussion after the third talk.
Thank you, Janil. Thank you, everybody, for giving me this opportunity to present such an interesting discussion which we are having today. And I have one case which actually saved my day. Are my slides running?
Yes, they're visible, please.
Okay, so yeah, so I'll just start straight away with the case that I had one case who the patient was 28-year-old, and he came to my clinic with a presentation like this, who wanted to get the eye corrected, which was already operated at the age of 5 years. And somewhere else it was diagnosed to be having type 2 DRS. He gave a history that he was already operated twice, once at the age of 5, and maybe the second was at the age of 10. The first surgery was still okay, but the second surgery did not give much of improvement in the vision, and he thought that he should try one more because he was planning for the jobs which were not very appealing because of his appearance. So going ahead with his previous photographs, which luckily we had, this was after first surgery, where the deviation is almost same like he was having now. And the motility limitation was also there. Like you can see that the right eye adduction was still limited. So on 9 gaze examination, we could see that the patient in the right eye is having adduction limitation of almost -5 to -6 with little bit of conjunctival scarring medially. He also gave history that he was operated in the left eye as well, where we could see that the abduction in the left eye was -1 limited. On MKT, he had almost 70 to 80 PD of exotropia. His otherwise clinical examination was normal, except that anterior segment had a little bit of scarring on the medial side. Rest of the things were fine. So we were thinking that what should we do? I mean, I was thinking more in terms that there was a slipped muscle, or maybe really there was not many palpable fissure changes. So I was thinking more in terms of slipped muscle, or maybe it is a DRS, we don't know. So I decided that we should plan a MRI, like we have already discussed, that whenever we have some restrictive strabismus or a strabismus which is not fitting into the normal kind of thing or resurgery, is better to plan or have a good dialogue with the patient to really talk about the outcomes of the expectations of the surgery. So I decided to go ahead with the MRI scan, and on MRI we were actually surprised looking at the pictures which the radiologist gave us. So in the first image we can see that on the coronal section the medial rectus was very huge compared to all other muscles. On the axial scans, you can see that the bulk of the medial rectus was very big, while that was still mid-orbit, but the posterior orbit, the muscle was actually atrophic, and the mass was actually coming through the muscle itself, and it was homogeneously enhancing on contrast enhancement. So we were confused, and the radiologist gave us a differential diagnosis. It could be an intramuscular hemangioma, could be a choriostoma, or maybe a nerve sheath tumor. And but because there were no fat stranding, there was no bony erosions, there was no other adhesions, the radiologist gave a clue saying that maybe it is a benign tumor. But when we discussed with the patient that this looks like some tumor, and we would like to see that what it could be possibly, does it progress, or should we have some other vision threatening problems? Because of this, the patient agreed to go for exploration of the medial rectus, and we actually planned the surgery. So when we opened through the fornix incision, we could see that the muscle was very huge. It was salmon colored throughout the substance, same consistency, fibrinous consistency was there. And we took a help of our oculoplastic colleague to go to the posterior extent. But throughout the extent up to the mid-orbit, the muscle was very huge. So we decided that we will take a biopsy of the outer aspect as well as inner aspect to see that what could be the possible reason of this muscle tumor. And it came out to be positive for the muscle for mesenchymal cells, which was CD34 positive, and it was reported to be as a mesenchymal fibroblastic tumor, which is a very, very rare tumor of the muscle. So that's how I came to a conclusion that now I keep myself updated that whenever there is a resurgery with large motility limitations or a severe scarring, which I am seeing, or palpebral fissures changes are there, or a restrictive or long-standing paralytic strabismus where you may suspect something which is very unusual, or in complex strabismus or incompettent strabismus, I try to keep my option open for neuroimaging before planning the surgical intervention for these patients. Thank you.
Thank you, Sampada. Really interesting case, and I'm sure this is going to be very unusual and probably once in a decade kind of experience. But the important point is that if there is something which is unusual and does not follow the usual rules of strabismus, then it is better to have some imaging modality so that you are well prepared and you can explain the patient. Moving on to quickly to Dr. Jaspreet's. Dr. Jaspreet is a senior faculty member of again PGI Chandigarh and has extensively worked in pediatric ophthalmology as well as strabismus, and he is going to today show us a very interesting case where he has again used ASOCT to guide the position of the muscle in management of a strabismus. Dr. Jaspreet, over to you.
I don't know if he's muted. We can't hear him.
Dr.
And can
Jaspreet,
you go to slideshow, Dr. Jaspreet, please?
We are not able to hear you, and
I'll just share my screen.
Yeah.
yeah.
Yeah. Can you see my screen?
If you can go to the slideshow, we can see the screen.
Yeah, I'm going to slideshow. Yeah. Is that okay?
Yes.
Yeah. First of all, thank you to the AI Scientific Committee for having me part of this webinar. Of course, a very interesting webinar. We don't hear that often about re-surgeries. So I'll be talking something, carrying things forward about how ASOCT helped us in doing a re-operation in a patient who was operated quite some time back. So this is, sorry, I don't have the initial photographs because I didn't expect these things. So we have an 8-year-old child who had inward deviation since childhood. So this is obviously the parents gave me this photograph, and there was no contributory family or birth history. The vision was 6/6 in both the eyes. The ocular movements were full, and the child had an alternating esotropia about 45 prism diopters. Now I did a bilateral MRI session of 5.5 millimeters, which was done. She was fine for a year, and then she starts to develop a conjunctive exotropia. And this is one of the photographs again the parents gave me. You can see here what's happening is there is limitation of adduction here, although it was crossing the midline on the examination, but of course it was a -2 or a -3 limitation of adduction on the eye, which was in the right eye. So bilateral MRI session was done, and she now presents with consecutive exotropia, which was measured to about 35 prism diopters. There was limitation in the right eye. Now, what would have gone wrong? What could we do about this patient? So she presents after a year. So it could be a stretch scar, probably the most common thing which would happen in such a scenario, pseudotendon stretch scar, or it could be a slipped muscle with a scar. So slipped muscle usually presents immediately post-op, but then getting a stretch scar along with a slipped muscle could be a possibility. So before managing, of course, here comes the help of ASOCT. So if you see the medial rectus of the right eye, which has a conjunctive exotropia, what we are seeing is you see the thickness here, the hypoechogenic area. Now this is actually the medial rectus, and you have a thin hypoechogenic scar which is going in front. So it is continuous with the muscle and it's almost inserted anteriorly. And this measurement was about 5.3. So that would be about 6.3 millimeters. You add a millimeters to it. In the left eye, the medial rectus was at approximately 10 millimeters. So you take 9 millimeters here and add a millimeter. So the left eye medial rectus was fairly fine, but the right eye had this problem. The lateral rectus, as you can see, it's unoperated. So it's at its position where it should be. So if you see intraoperatively, what was seen in the right eye was, if you see this longitudinal fibers going here, it was the bulk of the muscles are really here. So it was something like a stretch scar, which has occurred and probably which has resulted in the consecutive exotropia. And when we measured it intraoperatively to just a millimeters from what the ASOCT had shown. And if you can see here, when I'm just passing the suture here, you see the stretching of the fibers here, the longitudinal fibers which are attached. And of course, what we did here was we did a right eye LR recession of 8 millimeters. The MR was resected. I basically removed the stretch scar, so just call it a resection because it's difficult to differentiate it from the true tendon. And it did a 3 millimeter advancement. And after 1.5 years of follow-up, what we have is a child with almost orthotropia. And you can see here the movements are fairly good. So that's how the ASOCT helped us in delineating what it was, although, of course, we had to intervene even if we didn't have the machine. Thank you.
Thank you, Dr. Desprez. Very interesting case. And of course, the plan of management because of this will be very clear in your mind. If it is done by yourself, of course, muscle to tackle, but still if it is done by someone else, then it is very clear. I would like to invite comments from Dr. Shubhangi, Dr. Jyoti and Dr. Ramesh about how much do you rely on imaging, any kind of imaging now with ASOCT being there, and what are the other modalities you use when you are planning surgeries, when you don't have the information of the prior surgery specifically?
ASOCT, yeah, Jyoti,
Go ahead, no problem.
Yeah, I just wanted to ask Savleen that how should we start looking at the AS, how should we start imaging with the ASOCT? Because I have not done it so far.
I think 1 minute before Savleen speaks, she has a very good article. And if we all read through it, we'll really know. So when I have heard her talk, after that, I went through her article. And she's really explained well how it should be done. So if you're looking at it, and after that, we've also been doing it. So I think it's not mandatory, but wherever there are re-surgeries, it's always good to have supplementary, imagings like this ASOCT, UBM, MRI, wherever in doubt, especially for people who are not used to doing regular re-operations. It's always better to look at all this so we get a fair idea what we can expect. Obviously, it may not be 100%, but at least something is there, so we won't be totally, off guard when we are going in. So yes, Savalin, you can add, but I think she has a very wonderful article which all of us can read and get very good inputs on that.
Ma'am, I think Dr. Jyoti really answered. So doing the ASOCT, ma'am, actually the anterior segment surgeons are, I think, better. The technicians will be better in doing the machine, but interpretation, I think, is what we learn over time. So we sit together and then we try to analyze, and we've been learning by doing. So I think that is the best way forward. You just start doing it, and interpretation, you can sit with your technicians while you're doing the scan so that they can tell you, okay, how it is done. But then interpretation, I think we learn over time because that's what we want. One
quick thing for Sampada. What did you finally do with the patient?
Exactly.
Publish the article.
No.
So with the patient, not
No.
about
What did you do? Excision or whatever?
Yeah, so actually we did excision biopsy because the tumor was so big. I explored the other eye LR. It was already at 17 millimeter from the limbus in the left eye. So I spoke to the patient before surgery only that we may or may not be able to do the surgery in the first go, and the first surgery will be only to understand that the tumor is benign or neoplastic. So after the biopsy report, we spoke with the patient saying that we will do the debulking and we'll try to shave off the tumor as much as possible, and then maybe after that we will decide for one more surgery. But the patient got scared because I spoke about shaving the tumor, so he came one more time, but he is like, ma'am, just make sure that it is not turning into neoplastic. So that's what I want. I don't want cosmesis, so I didn't do anything. But I had kept my thing that I will take a help of my oculoplastic colleague and try to reduce the tumor, because it bled a bit, but it was not torrential bleeding on table, because the differentials given were like hemangioma and nerve sheath tumor. So we were a bit worried about how it could be once we take a small bit of biopsy. But luckily, it was not very big, like profuse bleeding on table. So I gave the patient 2 options. Patient opted for not to go for the surgery.
You said
I was wondering that after excision, you would have done belly transfers to correct the adduction, because it was the middle rectus was totally non-effective as -5, and there was the distal part was thick and the proximal part was almost thin. So you had to do an excision and do a belly transfer, modified Nishida's procedure to correct the adduction, I thought.
Yeah,
you
That's
said
what my
that
plan was actually.
there was a scar. You said there was a scar in the right eye on medial side.
Yes, so there was a small scar which we could see on the slit lamp, and there were some bubbles also, like globulate cells kind of thing, which we see. But when I actually took the patient for the surgery, there was not much of scarring. Even the muzzle felt like it is not touched so much. So most likely the first surgeon had seen the medial rectus and decided that to cover the XT, he will do both eyes LR recession. That's what I felt when I opened the case, because anybody who will see that muzzle will actually leave it like that, thinking that maybe it won't work. So that's all. So we have submitted
Thank
it.
you so much for the discussion. I think in the interest of time, we have to move on to the section 3. I think we have nicely summarized the first 2 sessions, that the algorithm of approach as well as the role of imaging. Now we'll move on to the session 3 about certain videos and interesting cases. Dr. Manju, over to you.
Sure. Thank you so much, Janil. So we'll move on to section 3, and we'd like to invite some more panelists. So Dr. Sumita Agarkar, who is Director at Shankar Netralaya, Dr. Pradeep Sharma, Dr. TSS. If you could please give your inputs, and we'll begin with the talk. So this is more about slip muscle. We have a talk by Dr. Swati, No, sorry. We have a talk by Dr. Jitendra first, then General, and then Dr. Ramesh Kekunaya. So, Dr. Jitendra, can you please share your slides? And this will be an approach to slip loss muscle, when, what, and how. Thank you. So, Dr. Jitendra is the leading pediatric ophthalmologist at Baroda. We all know him. He doesn't need an introduction. Go ahead, please.
Thank you
Thanks.
so much, Manju. And it's an amazing session. I would like to congratulate you, Dr. Janil, AIOS, for bringing out such a wonderful session, wonderful cases. My congratulations to Dr. Sampada. It was a very interesting case. So I would be speaking on slipped or lost muscle. And I would be giving an overview of what is known and what do we do. So the major difference between a lost muscle and a slip muscle would be that when you have a lost muscle, basically it is the fact that the extraocular muscle completely slips free from the sutures or from surgical instruments. So like while you're doing surgery, during the surgery, the muscle is completely gone. And a slip muscle occurs when at least some part of it is attached to the sclera. And mainly it is the muscular capsule where the muscle has retracted. So that is what is the major difference when it comes to the actual anatomical difference. And a lost muscle would constitute a real surgical emergency. We should make immediate surgical attempts to recover the muscle. And so a very common, not very common, but one way of getting a lost muscle is PITS, which is pulled into syndrome. What happens here is that typically it occurs at the junction between the tendon and the muscle, and that results in the loss of posterior muscle belly. And a quick fact about re-surgeries that there was a study which published that almost 10.6% of patients seen for corrective surgery after an unsatisfactory outcome from a previous surgery had a slip muscle. So when to suspect, this was one patient which was sent to us during the surgery for intermittent exo. The medial rectus was lost, and they had done the MRI. This is post surgery. The patient was very apprehensive, so we gave a Botox to left lateral rectus and did the surgery here to bring it in the primary position. Patient was going to get married, so they wanted straight alignment. But when to suspect a slipped or lost muscle? When there is mild to moderate limitation of duction in the field of actual action of the muscle, there is unexpected undercorrection or overcorrection, there is large secondary deviation. You can see in this particular patient that there is a large secondary deviation when the patient tries to fix with the left eye. And then, in most of the cases, it is quite clear that something has gone wrong. We can do specialized testing like saccadic velocities, which would be reduced. Force generation, force duction test can easily distinguish between whether it is a restrictive force or, or it is a slip muscle. Now, this is another case which we recently operated, and we had operated the patient for right eye brown syndrome with esotropia, and this was pre-op, and luckily we had recorded the video, and this was the medial rectus which we are recessing. This was my own first case which I saw post-op after a week. Now, these were the suture bites. So quite long scleral bites we have passed. And this was only after the review, after we saw the patient post-op. And this is the second bite, just showing the bites, and we'll move on to post-op. Just to see, this was post-op 7 days. There was exotropia in the primary position and limited adduction of the right eye. So we immediately rushed to the theater and we saw that the whole medial rectus was detached. Luckily, it was very easily, we could recover it and suture it back to the sclera. So we could retrieve it very easily. That was a good thing. And this was, we did a multiple anchors so that we don't have that. This is post-op. And so we got a good result because we immediately acted on it. This is post-op, just to show the adduction and abduction. Now, the gold standard obviously is to go back and see. And the most frequent muscles which are involved in slip or lost muscle are inferior rectus and medial rectus. Medial rectus being more common. Both the cases which I showed, one mine and one which was referred, was medial rectus, mainly because they have a shorter arc of contact and there is no intermuscular septum, or there is no other attachment with other oblique muscles or anything on the medial rectus side. So risk factors are tight or contracted muscles, poor overall systemic health with extensive scarring from the previous surgery with a tight muscle. This is mainly a risk factor for PITS, and strength of adhesion post-operatively mainly depends on location of the pre-placement suture, suture imbrication in the muscle, suture tensile strength, adequacy of scleral pass, and integrity of knot. A very good article by David Coate, where he suggested that the location of pre-placement suture was very important in muscle slippage. And they reported that if you place the sutures 1 millimeter from the insertion, there's a force of 688 grams versus when you place it 0.5 millimeter from the insertion, which is less. And how to manage these muscles, because when you have a lost muscle, you should try to make an attempt to retrieve the muscle. And if the muscle cannot be retrieved, a transposition surgery has to be considered, because if you do a transposition surgery, you have already lost one muscle, and then there's the chances of intersegment ischemia. So as Dr. Pradeep Sharma was talking about, belly transfer or Nishida or some similar vessel sparing procedure can be done. And depending on location, a posterior orbital approach with the aid of our orbital surgeon can sometimes successfully isolate or retrieve the muscles. So a slipped muscle can be repaired during surgery by locating the muscle capsule attached to the globe from prior surgery, and by following the muscle capsule posteriorly, the muscle itself can be found. This is for the slipped muscle, not for the lost muscle. So most important point in all this slip and lost muscle is to prevent this. So what should be done then? The bites passing through the muscles should be full thickness as far as possible. If we believe that a particular muscle may end up into into a slip or a lost muscle, if the muscle is very tight, you can use special muscle hooks like Wright's groove hook, or you can use Sew's muscle hook, which you can use for hooking the muscle, so that you don't pull them into two, or when you are passing the suture, you should be able to get so when the muscle is very tight, sometimes we have a risk of going through the sclera, and so these special hooks can help there. And instead of using two locking bites, instead of using one locking bite, you can use two locking bites to have adequate capture of muscle. I found this one interesting article on the difference in muscle slippage according to scleral suture technique in muscle resection. And so what they found was, if you use a technique where you have a central, after passing the muscle, you have 2 points where you pass the resection. If you do a central pass, another central pass, that helps in reducing the slippage. So this is also an interesting fact, that if a strabismus surgery is performed by the same technique using the same suture material, it is basically the inadequacy of scleral suture technique which will be the single most important factor for muscle slippage, if at all there is a slippage. So in summary, we should plan for prevention by using meticulous techniques. We should be gentle, and we should take full thickness bites. If the deviation is unexpected, with restriction of motility post-op, think of muscle slip or loss. Diagnose early in post-op period and take up the patient for resurgery or intra-op inspection. And while retrieving the muscle, be gentle, follow the capsule, and look for remnants of the suture if it has been operated by you. So thank you so much. Thank you for the invite.
Great. Thank you. We lost. Okay. Thank you so much, Jitendra. That was really great. I think your talk covered everything that we really need to know about slipped and lost muscle, including staying calm and remembering all that you've taught us today. I think we'll all be champions in managing such cases. So let's move on to the next. We have Dr. Janil Seth, who will be discussing a case of slip muscle. Janil, over to you.
Thank you, Dr. Manju. Am I audible?
Yes.
When
slideshow.
When Dr. Manjushri and myself were trying to allocate and make this program, till that time I did not have a slip muscle case, and then the next week I had. So I have my own. Probably I've not done enough to have it, and now probably I've done it. So okay, moving on to the presentation. It was a very usual, just a usual case for me, a 41-year-old who had been using glasses for last 5 years, and he had was diagnosed of strabismus since childhood, but and also advised glasses, but he was non-compliant, and just since the age of 37, 36, he started using glasses. Interestingly, he had a normal anterior segment examination, and we can see that he was high hyperopic with some anisometropia as well as mild amblyopia. Stereopsis is, of course, worse than 400 seconds of arc with left eye suppression on both Podot and others sensory examination. He had a normal extraocular motility, nothing unusual. We did a prism bar cover test, and unaided he was 55 prism diopters, comitant strabismus both for distance and near, and with his hyperopic glasses of +5, +7 in the right and left eye respectively, we saw that the esotropia was 15 diopters lesser. With this, we made a usual diagnosis of partially accommodative esotropia, and of course this is decompensated, and probably the hyperopic correction is helping in some amount of correction of the strabismus, hardly 15 prism diopters. And we offered him that there is a surgical correction which can be done even at this age. And this was my plan for this patient for 40 prism diopters, keeping in that the measurement over the +5 and +7 is, of course, is what I'm under measuring. Like myopia, we tend to over measure here. There is a chance that I'm 5 prism diopters under measuring. So I kept my target around 40 to 45 and a plan for 6 millimeter recess and resect. I have taken snapshots of the video because we have a video presentation next. So I planned, it was a unilateral surgery. I planned under local anesthesia. Conventionally, I go with recession first as compared to resection. Weakening before the tightening. But in this case, the patient was apprehensive. I had a very nice exposure of the lateral side. So I started with the resection procedure first, planned for 7.5 millimeter of resection. So under local anesthesia, approached the cul-de-sac. This part went pretty smooth. I was able to resect the adequate portion, brought back the muscle to the original insertion. And the routine, I started going for the medial rectus. And I started having some issues in the medial rectus immediately. As soon as I hooked, I found it very lax because the FDT, I did it before the local anesthesia, was normal. I did not find anything unusual. I could see that I could actually pull the muscle quite, superior anteriorly, like towards me. So I found it to be very lax, and for such long-standing ET, you tend to have some tightness of the medial rectus over the period of time. So I was wondering, I started more exploring, and like we see here that there is a small strand of the medial rectus muscle here, the inferior portion. So I have one hook which is going through there, and another hook going through possibly just through the Tenon's capsule. And again, in the image to the right, we can see that there is a double hooking happening where I have this portion which is hooked with my which is the Tenon's capsule only, and the other is hooking the muscle. So there were dual planes. I realized that something is going wrong, and then I started exploring little further, not moving the eye. So I used the retractor to explore the posterior part of the medial rectus muscle. I realized that I can see a stump here, which I'm holding here, and a very small strut of the medial rectus, the inferior portion, and the superior half was probably missing. And to be very honest, I hardly did any dissection with the sharp scissors. It was mostly blunt. And this portion which I'm hooking again is the Tenon's capsule, as you can see, which we can stretch very easily. So piecemeal, I started tracing the capsule posteriorly to hoping that the medial rectus would be found, the remaining portion. And I feel so that I got most of the fibers of the medial rectus, and as you can see, I secured with multiple sutures. First, almost 4 sutures I used to secure whatever I felt like a muscle, and did some blunt dissection to see if I can see the muscle fibers. And I thought so. The original plan was to do a 6 millimeter of recession, but I put it at 5 millimeters, thinking that I have lost probably the superior 1/3 of the medial rectus muscle, so probably the resection effect would be more. Day 1 post-operative, unusual lid edema because of the too much of pulling and stretching of the muscle. But we can see that there is a -2 adduction limitation. The abduction, abduction is quite fair. The alignment is still in esotropic position. 1 week later, we can see that the motility is quite good. There is some amount of narrowing of the palpebral fissure, but there is a small residual esotropia of 12 prism diopter. This was unaided. And post-operative 6 weeks, I could breathe a little bit more relaxed way because the motility is quite good. We can see the PFH now turning into normal. There is not much of reduction of the PFH, as well as the alignment has come quite beautifully. So this is something, a very simple case with probably we thought it would be a cakewalk, and we had this unusual presentation. Probably I wanted it for this presentation, and it happened somewhere in the back of my mind. So to summarize, so early identification is very essential, and the feel of the muscle is very important, and there are certain anticipatory measures that the muscle is expected to be slightly tighter, and if you see it is too lax, that means you have either missed it or you are just holding the tenons. It's very essential that not to panic, and very rightly said to stay calm, because we tend to move the globe too much and you see the muscle retracting behind, specifically the medial rectus, because it is very shorter in length and has a very less scleral contact. So minimal globe movements to avoid further retraction. Best is to use even an oculoplasty instrument like Dima's retractor can be used to retract the conjunctiva as well as tenons, and gently go into the depth of the orbit and try to focus, adjust your lighting again, try to focus on the muscle fibers and retrieve it with forceps. So tracing the tenons capsule, if you identified very correctly, the anterior and the posterior tenons will possibly lead you to a retracted muscle. Specifically is a partially retracted and some of the fibers are still in your hand. Thank you so much for patient listening.
Thank you, Janil. So that was really interesting. So your case of slipped and saved muscle by Janil, and all those learning points that you've shared with us. We'll move on to the video presentation, and I invite Dr. Ramesh Kekunia to share some more secrets on saving slipped and lost muscles. After that, we'll have a panel discussion. So over to you, Ramesh.
Thank you, Manju. Thanks for this opportunity. I'm going to talk about I'll show two videos. It's very quick. I think Janil and Tithani has made my talk very easy. Before showing that video, I just want to say that muscle is never lost. It's somewhere in the orbit. You have three forms. They are all, I think it's a spectrum. One is the scar gets stretched, that is the stretch scar. The muscle slips within the capsule, that is slipped muscle. And the last thing is muscle is gone beyond the capsule, somewhere in the orbit. Time we call it as it's lost. That's number one. Number 2 point is, as Jitendra said, if it is acute condition, we can try to retrieve it. It's possible. If it is chronic, it's not that we see lost muscle or really largely slipped muscle every day. It happens very rarely. It's very, very difficult in a chronic unless you do a transposition. And last thing, which is the most important, we should have a lot of luck when you deal with these patients, because you can get really lucky in many of those patients. So this is the routine case. I do say routine because it was a sensory esotropia because of coloboma involving one of the both eyes actually, but it was involving the macula in the left eye. That way, there is some microcornea is there. Resect with the downshift was planned for this patient. You can just see this video. What happened? Lot of tenons. It's been cut and planning to do a medial rectus resection. So whole test is being done, and really it's a routine one. What happened here? Routine surgery, but I always say that nothing is routine. Probably the assistant pulled it too much, and I just went to change my clothes into normal. I get a call that this is something wrong. At this stage, I come. Again, as Jitendra said, don't panic too much. Just go in there, try to hold on to the tissue. And first thing I will do is suture as much as possible. Because no suture was passed for this muscle. You can see sometimes it can look like a tenon, sometimes it can be that typical pink muscle. So then you can. This is what I would say. Luck and the timing is important in this case. One thing we all, I think the budding or the junior or with less experienced people, what you have to do is whenever you do a recession, try to drop the muscle somewhere and don't do anything and try to pick up, because this is something practice you need to do in every case. So this was done for this particular patient. Resection of the lateral rectus was, we didn't do it. She got a good cosmetic. Here, I would say timing as well as just go there and hold on to the tissue and bring it back and suture it, we could retrieve it. So this way, whenever you do a medial rectus recession or lateral rectus recession, once you disinsert the muscle, leave it into the orbit and try to hold without moving the globe. This is one practice everybody can do in their day-to-day surgery. That way, when this severe case happens or an unexpected complication happens, you have something to do. This is one of the case where a pterygium surgery, they cut the medial rectus. This is a long term. It's not, he's coming after almost 4 or 5 years. You can see he has a adduction limitation. I know the time factor, so I'm trying to move it a little bit. We did the force duction test. It was typically very tight lateral rectus because it's so long standing. What we did is, we did MRI also. We could see that muscle is there. And we took up the patient for topical anesthesia. Every patient, we can't do it. There are selection criteria. In some of the patients, we can do it. You can see it's not a typical incision, fornix incision. We really extended it because there was a lot of scar there. And then try to suture. That's not the muscle. That is not the muscle what is sutured. And then we went behind and sutured some more tissue. And we pulled the whole connective tissue and the muscle, so-called muscle, and intraoperatively you can see the eyes are moving. We double-checked it, whether it is okay. We also did the lateral rectus muscle recession at the same thing. You can see the eye movement. You can't really expect everything to move because the muscle will be still painful. But he got a not so bad correction immediately. You can see after the topical anesthesia, he was made to sit up, and then we could do the cover test. And this is the pre and post. We could not get the whole muscle, but we could get some muscle, because that's why you will see adduction limitation is still there in this particular case. And because of time factor, I think I'll stop here. These are the 2 videos. I just had one more video, but I'll probably stop here. Thank you very much.
Thank you so much, Ramesh. So this was a real interesting section of finding the muscles, staying calm, trying to not panic when everything looks red. I don't know why you had that food in the beginning. I thought you were thinking of going to add some dinner comments as well. But
But
I'll
some
move on to
spice
the
there,
panel.
that's why.
Move on to the panel. So I'd like some comments from Dr. TSS, Dr. Pradeep Sharma, and Dr. Sumita. I think collectively they have, what, 130 years of strabismus. So we'll see how many slip loss muscles you have encountered, or any tips that you'd like to share with everyone, please.
I just had one of a doctor under local anesthesia, and I was trying to resect the medial rectus. It was a divergent squint. And unfortunately, I think it just slipped, because I use a technique where I just clamp the muscle and then put the sutures underneath, and I think it was little suicidal. So the muscle just slipped and went away, and there was no suture. And all I tried was, I think, through the conjunctival side, I went through and then tried to retrieve, but I was not sure whether the muscle was there, like what Ramesh told. I think it was, I think, behind the capsule. And the thing, I used the EMG machine. It was a long time. So EMG machine, which I used for buttocks.
Yes.
So I just kept pulling the muscle and then started using the tungsten needle, which when it touches the muscle, it will honk. So the EMG machine will honk. It was next to us. It was kept in the operation theater. So when I touched the muscle, and once it was honking, I just immediately caught hold of the muscle. But I went actually along the conjunctival side. I never bothered to go towards the global side. And this worked out very well. And I picked it up, and the doctor actually was very happy that it became an orthophoria, because the muscle was back and it was just sutured. But whenever I do, a lot of times I do tenotomies, free tenotomies for thyroid problems, etc. That time what I do is I put an anchor suture on the muscle which has been tenotomized. And suppose you have an overcorrection or something like that, that anchor suture which I leave behind with almost an inch of virgin silk with the double knot, one knot at the edge, one knot at the muzzle. This
Right.
actually you can just go and pick up the muzzle. And I think stripped muzzle, I don't think the usual routine procedures, I think we have fixed it up. There's no problem. I also had one case of pterygium that was very long time. No, it was not pterygium, it was endoscopic surgery, DCR. They have cut the medial rectus. So all I did was I just R and R and R I did, all the three muscles maximum. So made it cosmetically acceptable, but adduction was not there at all. This was just for a DCR, I think, doing endoscopic surgery, they cut the medial rectus.
Yes.
Ramesh had same experience of pterygium.
Yes.
And I never had, after 40,000, I never had a lost muscle at all. Touch wood. I think Ramesh told luck is there. Luck should continue. I am still continuing, so let's continue.
That's a good one. Thank you. Dr. Pradeep Sharma, any comments from you?
Yeah, so my own cases, I have had one cases of a slipped muscle, or rather a lost muscle, I should say, an infantile esotrope. We had operated both the eyes, and one eye, after 1 week, he came with a consecutive exo. And when I opened up, I could not find the medial rectus. So after that, I learned one thing, that in infantile esotropes, what we routinely do, a single 2 bites we take and 1 knot we tie. In less than 1 year, I have learned that we should always have 2 bites, 2 separate knots. So that, because these children may sometimes rub their eyes so much that it may give way. So that's what had happened, that the muscle slipped, and medial rectus is so strong, it may go into the orbit. What Dr. Surendran was saying, that using the EMG probe, another thing which comes handy is that if you pull something what looks like a muscle and you have an OCR, so the help of the anesthetist can also help you sometimes, that you pull something and then he says, oh, the bradycardia is happening. So that lets you know that, okay, that could be the muscle. But you may be lucky to get it. Sometimes if you don't, then you have to go on to the belly transfer or the modified Nishida's thing. Other than that, we have had, in the past several times, pits because of the retinal surgeons handling the muscles, and inferior rectus, has been split several times by them. And that's what, sometimes they have themselves sutured and they have got away. And sometimes they have been, these cases have been referred and we have had to do the suturing of these cases, which splits at times. So that can happen by the rough handling, which I think most strabismus surgeons would not have it, unless it's a very fibrotic muscle, sometimes in thyroid muscles, that some of the cases we have seen have had pits in the Duane's retraction syndrome or a CFUM cases, very thin fibrotic muscles, that it can happen. So that is one thing which you have to keep in mind. And as I would like to emphasize, that doing the surgery under the microscope is very helpful in such cases. Particularly, you have good illumination and you have magnification, which is very helpful. So people who are doing under the loop or thing may have to switch on to the microscope to get to find out these muscles and do something. And never panic, never pull the globe, because the muscle will get retracted more. You may require a long bladed retractor, a Barbies, or we have a long tissue retractor, which helps in keeping the tissue away and then looking for the muscles.
Sure. Thank you so much.
One more experience I had with Dr. Badranath. He actually operated retinal detachment surgery, and he cut the inferior rectus and lost the muscle. So he called me, and I was just looking that what happened to the other eye. Other eye, he had no PL because he has had a retinal detachment earlier, and then he had no PL. So I told him, I think the eye doesn't look that much hyper. Best thing is you leave it alone. Don't go and probe. And fortunately and surprisingly, it so happened, I was very slightly hyper, about 15 prisms or so. And he was managing with that eye, no diplopia. So sometimes I think we'll have to use our common sense. not to go in middle again, and then you may cut the buckle and you may have a problem of the retinal surgery, what has been done. This also happened. And a number of times he has also sacrificed the vertex veins. That also happens. I think when you are doing oblique muscles, you have to be very careful. Vertex veins come on the way.
Yes. Sure. Thank you so much for sharing your wisdom and experiences. Maybe one last quick point from Sumita. Any tips you can give to the assistants? As Ramesh said, sometimes assistants are over enthusiastic when they are assisting with surgery. So, Sumita, do you want to
I
add?
think Zen mode is very
Meditation Zen.
important. Number one, Zen mode. Second, do not scream at your assistants or the nurse who is assisting you.
Never.
And third, you do retrieve the suture. Probably it's a good idea to use a non-absorbable suture sometimes. If you find that your muscle is very thin, you are not very sure, you can put a non-absorbable suture. That might help. Rest, I think all the points have been covered in Ramesh's video. And both the stalwarts here, Dr. Surendra and Dr. Sharma, has already. But it's very important not to panic, because panic definitely worsens everything else.
Thank you
And
so
yes,
much.
this is the only exception where we generally say 4 to 6 weeks for resurgery. But I think if you suspect a lost muscle, you should explore as early as possible.
Yeah.
No masterly inactivity here.
Yes.
No 6 rule here.
Yes, perfect. Thank you so much. So thanks for this great session, and I'll hand over back to Jenil for the last session. Thank you.
Thank you, Dr. Manjushri. We had an excellent first 3 sessions, and I think it covered a very wide spectrum of approach, as well as those surprises and management of those surprises. So last but not the least, we are moving on to the session 4. And before I begin the session, I would request, okay, Dr. Jaspreet is there. So I would like to welcome Dr. Jaspreet from BGI as a panel member, and Dr. Ramesh Pikune as a panel member for this session. And of course, this is the last session, and at the end, we are going to have a discussion with all the panel members. So basically open for all. First topic is by Dr. Swati Guljale. Dr. Swati Guljale is, can you please share your slide? She's going to talk on Cooper's dictum, and this we have been hearing from our fellowship days, that which muscle to choose, where to go towards the nose or temporally, and which is the muscle to be selected. So request Dr. Swati to please kindly share a slide. Dr. Swati is a professor at prestigious RP Center, and Dr. Swati, we are not able to. Are you able to hear us?
Yeah, she's muted also. Swati?
Swati, can you unmute? Yeah.
Yeah, good evening, everyone. Is my voice audible?
Yes, Dr. Swati, you have started screen sharing. We are just waiting for the screen to come up. Yeah, we can see the screen.
Yeah, so our slides visible and I'm clearly audible.
Yeah, please go ahead.
Yeah, good evening, everyone. Good evening, sir. How are you? I hope you're doing well. Good evening, Dr. Surendran. It's a pleasure to be here, and thank you, AIOS, for organizing this. Thank you, Janil and Dr. Manju, for inviting me as a speaker. I'll be talking about Cooper's dictum, choosing the same eye or the same muscle, or we need to do the other eye or the other muscle as far as our resurgeries are concerned. Right. So as Dr. Shalja has already spoken, that almost 5 to 10% of our patients will need resurgery, especially so if they are complicated cases, paralytic or restrictive. And there are no standard rules to approach these resurgeries. So what Cooper said, that you should treat resurgeries as good as first-time surgery and should plan accordingly, should plan your surgery according to the first surgery. But the doing resurgery is not so easy, and we may have difficulty in predicting the end result, because sometimes even if you do resurgery, there's a possibility that the deviation may come back to the original deviation, more so if it's a consecutive esotropia. So there's a possibility that consecutive esotropia, if done a resurgery, may go back as a exotropia. Second, the possibility of contracture of previously recessed muscle is there, and thus the result may still be unpredictable. Third, the portion of the muscle which has been resected has now become hypertrophied and fibrosed, and we still don't know how it is going to behave. So considering that, we always feel that doing an other eye surgery or the other muscle surgery will give us more predictive results. It also gives us some relatively intraoperative comfort because we don't have to deal with those scar muscles, that interop surprises, deal with pseudotension and the things that we have been speaking about through this entire session. So it's obviously a surgeon's comfort there, but patient may not be so comfortable and may not be willing to get other eye operated, especially so if it's a sensory kind of strabismus. There are disadvantage of same eye doing same eye or same muscle. The results are unpredictable. Many a times reports may not be available. There may be intra-observations and we may have to change the minute plan at the last moment. But depending on the presentation and the clinical examination, we have to tailor our surgery accordingly. So I'll be just showing few cases how we can approach the re-surgeries. So what to choose and how to choose. So this is the first case where the patient was operated and the patient had very large exodeviation, very before first surgery. So a maximum resection procedure along with inferior oblique was done in the right eye. However, the patient had residual, came back after some time and now had residual exo, again a very large exo this time also. So it was not a rocket science to decide this kind of patient because, one eye has already been operated with maximum measurements possible. And there was no obvious limitations of movements here to say that, there's a slip muscle or there's tight muscle. So we can go and, very easily do the other eye surgery with the maximum possible limits. Unfortunately, I don't have the post-op photograph of this patient. So maybe patient was well aligned, therefore it did not come back. So I cannot say at this point of time, but many a times you may be able to achieve good results with the second surgery. Now, coming to the second case, this was again a very interesting case where we had this patient who was already operated twice. Both right eye and left eye have been done, and there was only one muscle which was left was a right eye IO. So again, the patient had residual exo there, but more than exo, there was a vertical strabismus of around 20 prisms. We did FDT and we found the left eye adduction. As we can see in which is compared to this case. Mild association of the right eye also here, which makes us take a left eye surgery and do an IR application over here or reinforce the IO surgery. So since the deviation was more on this side, and we found that FDT was tight for the left eye lateral rectus, we chose to do the left eye. And this is we found intraoperatively, we found that the left eye was maximally, lateral rectus was maximally recessed as documented. But the IO was slightly more posterior as we had expected, as comparatively what we would expect in a case of anterior positioning. So we went ahead, we not only did IO anterior positioning, we brought it to the level of IR and did a complete anterior positioning. We also did an LR recession around 18 mm of limbus, as Dr. Agarwal was talking, that your limbus is what is your landmark as far as re-surgeries are concerned. So we did around 18 mm of LR recession from limbus. We also did IR plication in this case because the amount of hypertropia was much more than we could have corrected by the IO transfusion. So this is the post-op picture for this patient. She was in primary position very well aligned, and in spite of all this surgery, there was some kind of residual IR underaction in the down gaze in this particular case. So as you can see that, sometimes it may be difficult because all the muscles are operated and you don't know what you have to do. So doing an FDT and intraoperatively or maybe doing ASOCT could have helped us in this case, but we anyway had to reopen. So we thought we'll do whatever we can do. And this is what we achieved post-operatively. Now, third case is again a case, this is a case of consecutive esotropia There were no records available here, but we could see that there were scars both on the medial and the lateral side in the left eye. So we assumed that it was the RNR surgery in the left eye. However, as we can see, there are no movement deficits here, no patterns here, no obliques here. So we went ahead and we did the right eye surgery. For this case, we did RNR with upshift and downshift because of the pattern there. This is the post-op result. So the patient was very well aligned post-operatively. This is again a case of consecutive exotropia, where you can see that the patient has a exo of around 35 prisms in primary position. And along with that, we can see that there is limitation of adduction in both the sides, both on the dextroversion as well as on levoversion. And there's the small amount of hypertropia here in the left eye, more on dextroversion, suggesting of some residual IO overaction there. So in this case, we chose to do, as we have been talking throughout the this symposium, that whenever you have limitation of movement, we know that probably there is a slippage of muscle or probably there is underaction of the muscle over there. So here we went ahead and we found that the intraoperatively that the muscle was, instead of at 4.5 mm, was at around 6 mm. So we advanced the muscle to its original position. We also did the left eye IO weakening. And this is what the post-op result. The patient achieved the good alignment in the primary position, although there was some limitation of adduction in left eye in spite of our advancement there. But the patient was happy and cosmetically he was. This is the other case, again, consecutive exo and not an ESO. I have mentioned is base out here, should be base in there. So again, no records were available, but we could see that there were scars on the both medial rectus. So we assume that the medial rectus recession was done. And as we can examine, there is very minimal limitation of adduction in both eyes, very minimal. But the thing is that here there was a V pattern. So if we would have thought of advancing the MR over here, probably we would have worsened the V pattern. So we went ahead and we did bilateral LR recessions along with the upshift to take care of the V pattern. And this is what we achieved post-operatively. The patient was very well aligned. The V pattern was there, but quite decreased quite significantly. And the patient was happy. There's this another case where we had
up in a minute.
Yeah. These are just last 1 or 2 slides. So there's this another case, again, a patient of consecutive exo. Interestingly, the patient's exo was much more for near as compared for distance. And we can see here, even though the adductions are not that bad as in previous case, we thought because there is much more deviation for near, we went and explored MR. We did a mild MR advancement there along with the PTSO because there was severe A pattern there. So here, doing an MR advancement will not only correct exo, it will also help in correcting A pattern, which was so severe, along with the PTSO. And this is the post-op result. The A pattern is almost collapsed and the patient is well aligned for both near and distance. So to summarize, as we have been talking about, careful clinical examination, looking up the record or doing imaging if records are not available, what was the course of alignment, immediate post-op, taking for any IO residual overactions or underaction, missing of any pattern is what we need to do when we want to plan this surgery. The surgery has to be tailored. It's a tough call and each case has to be customized depending on the pre-op and intra-op finding. As has already been emphasized, doing a limbal incisions in such case may be a good idea, especially if you are not the primary surgeon. And doing an FGTs, both intra-op and post-op, definitely helps in deciding the course. Thank you for the patient listening. Thank you.
Thank you, Dr. Swati. A wonderful case, actually, and excellent. Each case was different and had a different approach. Moving on to next, I would like to invite Dr. Jyoti Matalia, who is going to present a very interesting case on what went wrong. With
Swati, can you stop sharing?
Oh, I'm sorry.
Yes.
Yes. Over to you, Dr. Yud.
Yes, thanks AIOS and thanks Manjushri for this opportunity. I think it's an entire feast for strabismologists today, because usually we see a lot of webinars on general strabismus, but this is about re-surgeries and not many much discussed before. So I think I congratulate you for planning it. So let me talk about what went wrong. I'm going to talk about re-surgeries in DRS. So let me start with one case of bilateral DRS, had undergone surgery. He was a 33-year-old male, had DRS in both eyes, good vision, and he had multiple surgeries, already 9 surgeries done, and he was still not happy. And he came for the final better outcome. So this was what was when I saw him in 2021. He had a left face turn of 25 degrees. Though he was left eye fixing, but when he had a right eye fixing, there's a left hypotropia. And with the left eye fixing, a large RXT with RHT. And at that time, we had a -3 abduction, a -5 adduction in the right eye, and a narrowing of palpebral fissure in the left eye on adduction. On fundus, there was an excyclotorsion explaining the RHT. So he had a 14 PD exotropia in the right eye and a 16 PD left R on L, because he was primarily a left eye fixator. At this time, we thought we should do an MRI because he has undergone so many surgeries. And what we found out, there was an attachment which could see in the right eye very subtly, not very clear. But this is what we found on the MRI. So let's see, this is how he was from 2018. You can see in September, then another surgery in October, then in December, in Jan, then in April, and then in October. So at each time, he was not happy with either the alignment not correct or the palpebral fissure not correct in both the eyes. So these are the 9 surgeries that he underwent, and primarily he was operated in the right eye 5 times. There was a multiple resections done, multiple recession. And what was important, the final surgery which was done in the right eye was the LR fixation to the periosteum. That was it. So what I decided is to explore his right eye, look for the lateral rectus, the medial rectus, because it was significantly displaced backwards, and the inferior oblique. So this was the surgical steps. As you can make out, there's a very tight FDT. And when we tried to hook the inferior oblique, it was much more anterior to the LR. And incidentally, the LR muscle was hooked to the inferior periosteum and also adhered to the sclera. So it is important that we properly disinserted the LR completely from the inferior orbital margin and disinserted it also from the sclera, totally freed it off. We cut the entire MR, LR, whatever was adhered, and then left it back significantly behind, because there was hardly any chunk of LR that was there. And an inferior oblique myectomy was done. So this was his post-op, no face turn, Hirschberg central, and he was very happy with the palpebral fissure. This was immediately after about weeks, so finally happy at 10. And I would just say that I was lucky enough. He went through 9 surgeries, but I was able to give him. So not that I did any heroic thing, but yes, I at least planned decently so he could be happy at the 10th surgery. So this is another case which I want to talk about, a left eye exotropic DRS. This is unilateral one. He had undergone surgery. As you can see, he had a large right face turn and a large exotropia in the left eye. And you can make out he had a -4 adduction in the left eye and a -2 abduction. Incidentally, as important, let's look at the old surgical notes, and that's a very important finding. Incidentally, it was done in my hospital. So we had a left eye LR recession done 9 millimeters behind with a Y splitting, and a resection of 6 millimeters done on an adjustable, which was finally recessed to 6 millimeters. So eventually the muscle was placed behind. So this is important. If you get the old surgical notes, they really help. But what also was there, look at the FAT scan. So if you look at his childhood photograph, it's exactly similar to what he had at present. So keeping that in mind, we were aware that's a left DRS, left eye DRS, anomalous LR function. So I planned to do, that is, disinsert the LR and put on the periosteal, fixated on that lateral periosteal wall, as we have been seen initially. So let me tell you exactly what we did. So I did a limbal incision because we know there's a Y split. See, it's so difficult to hook the superior bands because it's way behind. So look for it carefully. We sutured it and disinserted it, but they were fibrotic bands. Similarly, went and hooked and disinserted the inferior lateral, inferior LR bands, and they were not like a routine muscle fibers. So after that, we tied the bands together, and then comes the important step of the lateral periosteal fixation. And this is very important. First, you have to locate the lateral orbital rim, go behind it about 5 millimeters as posterior, and using a non-absorbable suture, go into the periosteum. This is very important. See, pull and see. You see the suture should not come up. So you're ensuring that's in the periosteum. Then you have to break all the additions these Y split bands had, and finally tie the particular suture that you've passed through the periosteum to this. And after doing that, you have to ensure that you make a proper suturing between your tenons, which keeps this muscle off from your sclera, because we don't want it to fall back and again cause an adherence. So this was the final outcome. He was having a fully corrected head posture, orthotropia for distance, and a small XT for near. Though the adduction limitation was only -3 now and abduction -2, he had an improved binocular single visual fields. So what I want to say is that lateral rectus periosteal fixation is very effective technique, provided you have taken the right indication. It's important that when you're doing it, it should be 5 millimeters below the lateral orbital rim for a version muscle, but for a recess muscle, go as behind as possible. You have to ensure that the muscle should not adhere back to the sclera. And for that, the intermuscular septum should be secured to create this barrier between the sclera and the LR muscle. And wherever necessary, a preoperative MRI is important, and try to get it read with a trained radiologist, especially in re-surgeries. So what the first surgery was, that somebody had done it, had not ensured that the LR was nicely on the orbital wall, and hence it adhered back to the sclera, and the patient landed up again with an exotropia. So unless you know the right technique, you may land up with problems. Thank you very much.
Thank you, Dr. Jyoti. Excellent cases, actually. And DRS is always challenging. Resurgeries is more. Moving on to the last but not the least, I invite Dr. Manjushri Bhate. She's going to talk on the challenges of adjustable sutures and redo surgeries. Dr. Manjushri.
Thank you so much, Janil. I'm going to be really quick. I'm just going to just cut short one video. I'll just quickly play this. So basically, we've been talking about resurgeries for the past 1.5 hours, little more than that. And what's really important in resurgeries is the role of adjustable sutures in trying to help gain a more precise position. So as such, resurgery challenges include pre and intraoperative challenges. So preoperatively is the planning based on the available information of the previous surgery, the current eye position, presence or absence of diplopia, and as always, the patient expectations, because they've already had one, maybe 2 surgeries. So it's not that they, they have some expectations that they come with. So trying to meet that is really important. And the intraoperative challenges of conjunctival scarring, more dissection that may be needed, locating the muscle, and then proceeding either with the plan which was originally made or deviating from that plan. In addition, when we're using adjustable sutures, the aims would be to try and give a more precise postoperative result, perhaps closer to patient expectation, to eliminate and or minimize the diplopia post-surgery. And the challenge is again based on how the muscle position is, whether it's an extra large recession or it involves tightness of the muscle. Especially, I would say, as compared to using adjustable sutures in redo as opposed to non-redo surgeries, the pain management because of the extra dissection. So cooperation from the patient, help from the anesthetist to try and give better pain management, and sometimes even delaying the adjustment for over 24 hours. I think these were the main take-home points that I wanted to share. And why aren't I moving? Okay, so I'm just going to move on to this case. So a thyroid case who needed a adjustable suture. Another, again, similar, I've done it more in thyroid patients who I would say have needed both resurgery as well as adjustables. So this was another thyroid case. And again, as we can see, the enlarged muscle bellies over here. This was the patient had previously had undergone a Botox into his inferior rectus, then underwent an inferior rectus stenotomy as well. And what I'm just going to quickly run through, I don't know, just what I'm going to quickly run through is, I know I'm showing the scarring, or there is a limitation and tightness of the inferior rectus muscle on force duction test. And this is a really edited video, but the scarring is quite extensive. It does not take 10 seconds. It takes much more time. And then trying to get the muscle, trying to hook it. I usually don't put an inferior rectus on an adjustable. Very rarely have I done it, but it's more often the medial rectus. But sometimes we do need to when the patient has these, especially double vision and high expectations from third surgeries or more. So I'm just going to show you this clip where I usually use a bow tie technique because I find that more easier as compared to a noose technique of adjustable sutures. And it essentially, I'll show you in this animation as well as in the little mask demonstration that I take. So this is basically a single knot, and then is a bow tie or a bow knot. So the second knot is the bow, and it's very easy to undo that just by pulling the shorter end. So once the shorter end is pulled, the single knot can be loosened and then the muscle position can be readjusted. So this patient actually did quite well. So some food for thought for discussion towards the end is how many prefer adjustable sutures, particularly for redo surgeries? Are there any particular techniques that you would prefer? And as I always feel that the pain management is quite important in these redo surgeries. So anything particular that you would go for? So these are the questions open for discussion. Thank you so much, Janil.
Thank you so much, Dr. Manjo. Excellent video, actually, an excellent video of the knot, very clearly explaining, very smartly done over the mask. I would like to invite Dr. Jaspreet, Dr. Ramesh for their comments, and of course, this is open to all the panelists for this session about their how do they approach otherwise a residual and recurrent cases where there is no motility elimination, no slip. Do you go to the same muscle which has been operated, or you consider this as a new case? And Dr. Jaspreet?
Yeah. So actually, Cooper's dictum is quite old, and probably at that time, probably the maximum amount of MR recession, probably what they were doing was 3 to 4 millimeters. And of course, they did not say operate, consider it as a fresh case. They did say that you see what is there a convergent insufficiency or is there a divergent insufficiency, what is happening, and accordingly operate. So it's basically what you have to do is a tailored approach. I mean, you have to see the amount of deviation, your versions, and of course, intraoperatively, you have to be ready to change your plans depending upon the muscle stiffness or the muscle laxity. So if there is a limitation in the direction where the squint surgery was done, probably yes, you will have to operate those muscles. But if there is no limitation, then probably what you're dealing with is an overcorrection and an undercorrection. You have to find out what it is. If it's an overcorrection without incompetence versus an overcorrection with incompetence. So if there's no incompetence, probably operate for the fresh muscles. But if there is an underaction, now we're talking about overaction, if there is an underaction, and if prior surgery is close to maximum, probably operate on fresh muscles. Otherwise, you could just go on previously operated muscles. That would be my approach.
Thank you. Dr. Ramesh, any comments on approach?
I would partly agree with Jaspreet. It's just that when there is no limitation, that's what exactly we are talking right now. It all depends upon how much is the angle. You know, if we can safely do the normal eye, where the angle is maybe 40 or 45, I would just do 2 muscles in the normal eye rather than just doing anything. But if it is crossing 65 or 70, where we might have to touch the third muscle, probably it's better to go to the muscle, see what is happening there. Sometimes, even if there is no adduction or abduction limitation, there could be mild slippage of the muscle. If the child is there, I would probably go back to the operated eye, because over a period of the next 10 years or 20 years, there is a chance that will slip. So I wouldn't really follow the Cooper's dictum. If the child age is probably 7 years, 8 years, I would still go. I know that the problem what they have operated, like typically it happens in infantile esotropia. You operated 1.5 years or 2 years, they come back to you at 6 years or so. Unless you really take care of that medial hiatus on both sides, over a period of time, you are risking this child to have a consecutive. Having said that, you know, patients who has some kind of consecutive 25-year-old coming back to you with 25 degrees of consecutive deviation, I would safely do the normal eye. So it all depends. And in Duane syndrome, one thing is that going back to the same muscle may be difficult sometimes because of the co-innervation. Like, for example, if somebody has a consecutive exotropia after medial rectus recession, because less is better in Duane syndrome, probably I would go to the lateral rectus than getting back to the medial rectus. So these are some of the typical things you need to. And the third thing is thyroid. Each case is different by itself, so I will take a case-to-case basis. These are the comments for these three talks from my side. Thank you.
Thank you, Dr. Ramesh. Wonderful. Just the last point, it's open to all panelists. So how often are we approaching for the resurgeries with adjustable sutures? And do you think it has a really an advantage that patient's expectation is more because this is a second surgery and they come with much higher expectation? Do you think adjustable has a little bit more advantage over directly going for a normal routine surgery?
I think adjustable should be done, especially if we have limited muscles at disposal. And adjustable gives a better chance for alignment in the second surgery.
Especially if the patient is having diplopia, then you need to have a diplopia-free position. So adjustable would give you a more predictable response. Particularly about the DRS case, I would like to make one comment. I mean, in exo-DRS, I wonder why somebody is doing an MR recession at all. Unless the FDT is tight for MR, which is very rarely so in exo-DRS, one should not do, I mean, this is the older thinking when we were taught that you should do a differential recession of both the horizontal recti. I think it's now very clear that in exo-DRS, one should not do the recession of medial rectus at all. It's only in the ESO-DRS and in the ortho-DRS that one may have to do an MR recession, which also should be to the, as Ramesh was also pointing out, less is always more. Regarding the thyroid, and when many times when we are doing both the IRs, which may have to be done, we have to be careful that it may cause a pattern or a outward shift in down gaze because the inferior recti are adductors, and especially these tight muscles are doing a lot of adduction. So when we are recessing both IRs, it may cause an A pattern exo. So we should do a nasal shifting of the IRs. And the other point which we have to be careful about is that inferior rectors are very prone to have an over recession over a period of time, especially in thyroid cases. So here there is a role of using non-absorbable sutures for the inferior rectors. So, I mean, if that point is to be remembered, even medial recti sometimes, there can be re-recessions if we are having a consecutive exos and you have to do MR re-recession, then probably using the non-absorbable sutures may be a good thing because some of these cases have stretch scars. And I have seen some ethnic people, especially from the Caucasian race, which I have seen, that they do have a consecutive exo because of a stretch scar. Probably their healing is less, just opposite to what the African kind of people have a more prone collagen healing. They have lesser healing thing. So you should be using non-absorbable sutures and probably avoid steroids in these people post-operatively topically.
Thank you so much. Wonderful pause, Dr. Dr. Manjushri, before Dr. SS gives the closing remarks, would you like to say?
So I think this has been a wonderful webinar. We all have learned, at least I have learned a lot from everybody. So thank you so much for everyone's active participation, for all those wonderful learning points about how to handle resurgeries in particular, right from the conjunctiva, the muscle, the sutures, as Dr. Pradeep Sharma said, adjustable or not, the tackling slipped muscles or all those wonderful cases. So thank you everyone for your wonderful participation. And I really enjoyed this. Was such a friendly webinar. So thank you, everyone. And we'll hand over to Dr. Somshila for her vote of thanks.
Firstly, I would like to thank Manju and Jenil, without whom I think this webinar would not be possible. And as it's really good to see that all the speakers think the way the two of you did, that everybody talks about strabismus surgery, but nobody talks about repeat strabismus surgery. And Jyoti, I thought that we were the only people who did surgeries 8 or 9 times, or maybe the retina folks. But looks like even squint specialists sometimes do 8 or 9 times. But jokes apart, it was wonderful learning, even for somebody like me who is very much not so educated in squint. And I think even I could pick up. So just for the audience, just want to say that it's same. If you missed any of the talks, all of them are available forever in cyberspace on YouTube, also on the Facebook channel and other media. So you can always go back and look at the wonderful videos. I think that I suspect that even it's not just that you're making it look simple. people are very, very refined as surgeons, and I'm sure it's much, much more difficult than what you did. And we had some amazing talks and amazing panelists. As Manju said, that there's so many years of experience that we have amongst the panelists, starting with Professor Pradeep Sharma, and then just about everybody who's there at the top at the panel. So thank you. I would also like to very quickly thank our back-end support, Bhupinder Singh and Sai from Numerotech, and the support for the webinar. And of course, none of this would have been completed but for the help and support from Professor Namrata Sharma, who's our chairperson, scientific committee, and all my co-scientific members. So thank you once again. We hope to see all of you at some other AIOS scientific committee webinars, and a very good night. And thanks to everybody who attended online and patiently listened on a Saturday evening. Thank you and bye-bye.
Thank you all.
Bye.